another really great question along that same line about having other people help you with that. What would a good thing to tell people briefly, either on a medical alert bracelet or just if you're in an emergent situation, that would quickly and easily convey that you have an Indiana pouch?
I have Medic Alert, so it's all on that for me. And like I said, both of my daughters and son-in-laws and my husband all know about it, so they would fill anybody in anyway.
What about you, Scott?
I really hadn't given it any thought. I mean, it's become such a natural process for me. And in my mind, I'm still younger than you. So, you know, I don't think about it, but now that I've heard this, maybe I should wear an alert. I am diabetic, well controlled, and you know, it wouldn't hurt to have something, immediate information should something happen that makes me unable to communicate. So yeah, I don't know the best way to go about providing that, a bracelet or something else. I have to look into it, I guess.
Dr. Laviana, is there something that you would see on a medical alert bracelet that would tell you exactly what you needed to know about somebody who had an Indiana pouch?
So I've seen patients who literally have it say Indiana pouch on there. I mean, God forbid, not you know, you get found down or there's a skiing accident or something, Scott. It's that way somebody knows. If you go to just the first emergency room there, they're going to look and really be confused as to how to proceed. And so it's just as simple as saying Indiana pouch can really go a long way.
Thank you.
Interesting regarding the Indiana pouch. So I'm finding some physicians really aren't even familiar with it. I kind of had to explain the procedure to one of my primary care doctors, and says, "Well, I've heard of it, but isn't that like a neobladder?" And you know, I guess there are differences that they need to be aware of. So,
Sure,
even other urologists, honestly.
It would seem that that simple phrase of just Indiana pouch gives the provider enough information to either do a very quick Google search or they'll know what it is. So I hope that answers your question. Speaking of primary care providers, we had a really good question about should primary care providers or a urologist do your annual, semi-annual urine check, or what the importance is in communicating that with your healthcare provider?
Before I had Dr. Laviana, Dr. Kraus would send the orders to me and I would take them to my primary care and he would run the tests and then I would get the results and I'd send them back to Dr. Kraus down in San Antonio. Now I let Dr. Laviana do it.
Dr. Laviana, do you think it's important for the urologist to do it as opposed to the primary care person?
I don't think that's a black and white. There's no black and white answer here. I think it really depends on the patient's relationship, both with the urologist and primary care provider. If they have a great primary care who they trust and communicate the labs back and forth, I think that's fine. One thing to worry about over time, same with the neobladder as an Indiana pouch, is that because you take so much intestine, you can get acidotic or increased acid load, and you can have sort of kidney function deterioration with time. And so someone has to be vigilantly following your labs at least annually to make sure your kidney function is good. And then as Sydney said earlier too, you can definitely get vitamin B12 deficiency, which isn't always checked. And so you have to be aware of that. And then I typically start a year out. You can probably wait a little longer, but again, because you're harvesting small intestine as well as colon, it's interacting with urine, you have to start checking urine cytologies, which is a urine test, just to rule out a secondary cancer that can form in people who have had these pouches for 10, 20 years here. So it's something to keep in mind.
Great. Scott, what is your experience with having your urine checked?
Well, you're always going to show an elevated white count because you're catheterizing to give the sample. So a primary care who say didn't know you had an Indiana pouch would say, "Oh, we better start on C-Pro, do a urine culture," which I get once or twice a year. But I think it can be overprescribed antibiotics when just drinking a lot of fluids, irrigating and washing it out. I mean, when you get up to a white count in the way up there, yeah, you probably need some type of antibiotics. But right now I had a urinalysis done for a minor surgery I'm having, and it was like 100, which was potentially, I guess, I don't know, 5 to 10 times abnormal. And I think a normal general practitioner would have started you on antibiotics where I didn't have any symptoms. And my infectious disease doctor, as well as my urologist, says, if you're not having symptoms, let's not start you on antibiotics. So I think it's something that needs to be, people need to be aware of. You just because you have elevated white counts and so on doesn't necessarily mean you need to jump on antibiotics.
Mhm.
Absolutely. And we had a couple of very related questions submitted, and they're about long-term ownership. One is about an overly stretched pouch, and one is about continual leakage. So we'll start with one and then we'll move to the other. And the first is, can a pouch become stretched out and floppy over time and more empty to progress? More difficult to empty as time progresses?
Yes, the short answer is that is yes. It can definitely get too enlarged, and I've seen these as large, definitely as large as a liter, if not 1,500 cc's. And in that case, it's not a perfect sphere. So you start as a circle, but then the lobulations and the shapes kind of get all over the place there, and it can get much more difficult to empty, and that's when you really get at risk of urinary tract infections as well as stones. The problem with this getting a stone in these Indiana pouches is it's not as straightforward an operation all the time as opposed to getting kidney stones the old-fashioned way. So it's something to keep an eye of. Scott, you're saying you're catheterizing every 3 hours, and can you expand?
No.
And I would say ideally, yes. The answer to that is you can expand, where that sweet spot is really 400 to 600 cc's of urine. But oftentimes especially with having it for so long, you can't expand rapidly, and this will be something you have to expand 5%, 10% at a time, and see how you do, and go from there.
3 to 6 hours, doctor. So during the day, I'm drinking so much fluids, alkaline water system in my house, exercising, walking. So 3 hours, but at night I'll get up to 6 hours of uninterrupted sleep. So,
Yeah.
but you're saying after 5 years, the potential for the pouch to still be able to expand more is a possibility?
Yes. Yes.
Okay.
That's awesome. It's good to know both that it can continue to expand, but B, that it also may get a little bit floppy and difficult to release that urine. Is there any sort of fix for that floppiness?
Unfortunately, not really, without an absolutely major operation that oftentimes is not worth undergoing. There's no easy fix to that.
I am sorry to hear that, but we'll cross our fingers for future fixes. The other question related to longtime owners is about leakage. And what about when people experience leakage past that normal thing, beyond the normal leakiness? Is there tips, tricks? Scott, Cindy, Dr. Laviana, what do you think?
I mean, I think this is one of the more common problems actually with Indiana pouches is the leakage issue that can persist. You have that valve, but then you have to throw some sutures around there to try to really narrow it down. But unfortunately, it's not an always perfect mechanism, and some people do unfortunately leak. Now, if it's to the point that you're putting a stoma bag over it or something to that extreme and it's not better, then you can go in and revise these to improve upon that continence mechanism. But one of the tricks here is to catheterize more frequently. I do see one of the comments here about catheterizing up to 7 times daily. And if you're still leaking at that, and that's going to be every 3 hours or so, I mean, you can try even every 2 hours, especially if you're going to go out and do an activity and you don't want to leak during the activity, is catheterizing right before and afterward. But if it's really, really uncomfortable or affecting your quality of life, I would seek a possible revision there.
I had 2 revisions myself. One was under general, and because of leakage, they repositioned my stoma, which is probably about 4 inches below my navel, so it's way down low. And that pretty much took care of a lot of my leakage. And then the second one was done just under local, where I developed scar tissue at the opening of the stoma, and Dr. Nitti was able to clean that up. And now I'm catheterizing like a hot knife through butter. So it's been fine. But it's not unusual, I guess, as Dr. Laviana said, not to that. Revisions are possible, and they do help me out greatly. And that was in the first year and a half or two. Since then, I've had no need for anything like that.
I wear a little pad that I make up over the stoma just to keep it because of the mucus, and it does leak somewhat. But it doesn't bother me. You know, I take it with me. I take a new one if I need to. I take my tape because I'm allergic to so many kinds of tape. I have to be careful what I use. But I haven't had any problem with the amount of leakage or anything that I can think of at all. And I had that one revision when it was on the right side. Then we had the big one moving it to the left.
I will mention an amazing product that I researched, and I've been doing it for almost 5 years. It's called a stoma cover, but this particular stoma cover, and I found a company, and actually Austin Medical Products, that makes it. I don't own their stock or anything, but they're just a cover, and it'll hold between 25 and 28 cc's of leakage. And it'll start to balloon up when you know it's filling up, you know, even before the pain. But again, it's very useful in an active lifestyle. It's called the SG3. They make a number of different ones. It's a flat little pad, but with great sticking capability, doesn't irritate the skin, and Medicare pays for it, by the way. So it's a super product, and I haven't found anything from any other manufacturer that comes close to it. Even other manufacturers have recommended it when I was looking for something else.
What were the initials? S what?
Austin Medical Products, AMP, and the particular product I use is the AG3. It's a rectangular one. There's also an oval one that doesn't hold maybe 12 cc's. They have different shapes and sizes and so on, but a terrific product.
Thank you all so much for that helpful information about leakage. Now we're going to talk a little bit about mucus. We had several questions come in about mucus. And the first, and I believe in your presentation, Dr. Laviana, you talked about how they take part of the bowel. And just because you take part of the bowel doesn't mean that your bowel stops functioning as a bowel, even though it's now doing a new job of holding urine. So can you talk a little bit about how that peristalsis, or the squeezing and expanding motion of the new pouch and stoma, can sometimes expel mucus or urine, and how that can be dealt with?
Yeah, there's actually, I see several of these questions line up pretty well here. So peristalsis is just the squeezing of the intestines to push things forward. It's how your bowel movements basically go from, you know, your stomach all the way down to the toilet. But you still have that motion of pushing forward. And for some people, that actually can make catheterizing more difficult. When you're catheterizing and the intestines are squeezing out, it can cause some pressure for that catheter. And it's also some of the concern of actually putting this on the left side and not the right side, even though, Cindy, you've done great with that. That's always a theoretical concern, is that it's going the opposite direction there. But also with that, because it's squeezing, you can have small amounts of mucus and urine sort of push out there. But a lot of that has to do with the overall continence mechanism of that valve and how it's sutured down below. If it's really so a couple things. If you have too much mucus, one of them is to really drink more fluid to try to dilute some of that, to help that out. And when you're irrigating, if you're just irrigating with 60 milliliters of saline, you can increase that to 120 or even 180 to try to get that out when you're irrigating. There's a comment made here about guanifacin to thin mucus, and that actually works the same way it does for your sinuses. And I have several patients who do use that to thin that mucus out as well, and it does work. These patients have done it for years, and it works fine. It can make you tired, and you just have to watch out for formulations that you can function well on. But that does help from a urinary or from a mucus standpoint as well. And so if it works for you, I say great. I don't discourage anyone from that. And there's also a comment here on that line about being a dairy user, and I take more when the usage is up. There's not a real link between dairy and mucus production per se. I think it's more with a hydration standpoint. But as Cindy and Scott said, that their mucus production did both decrease over time, and I find that to be more of the norm. Is that over time you still make some mucus, but it tends to go away. If not, then usually it's having to just irrigate more when you are doing that catheterization.
Great, thank you. And another diet-related question about eating fiber to increase mucus, or the correlation between fiber and mucus. Is that something that Indiana pouch users and owners need to worry about?
So the short answer there is no. I mean, fiber just overall has so many great benefits just from regulatory gut function in general. It'll make things move more. And that from an overall constipation standpoint and straining standpoint, you want your stools moving pretty freely. So I think that's a bigger long-term issue than the sort of byproduct of making more mucus, and it's not substantial in that regard either. So I would never tell someone to stop their fiber intake for that reason.
Great, thank you. We have one more question, and then we have time to do a little bit of a final thoughts. So the final question is there a way to stretch a tight stoma, or tips and tricks to navigate a tight stoma?
Mm-hmm. It's a common issue here, and Scott said he had something along those lines. And part of the problem is you're taking this piece of intestine and bringing it out to the skin, and that's the farthest area from the blood supply to that piece of intestine. And so oftentimes that area will stricture down because it doesn't have a good blood supply, and that can narrow and make it tight. No one should ever be really struggling to have to catheterize. You also want to rule out a peristomal hernia or something else that's causing this difficulty, or just a really tight angle. Sometimes the way these are positioned, you end up having almost an L or S shape you have to navigate through. If it's at the skin, it's actually there are many options to revise those, and they can be done pretty easily. Sometimes it's just dilation that can even be done in the office, or a minor outpatient procedure to basically revise or redo that opening. But it just really depends where the source of the problem is. Is it at the skin? Is it from a hernia? Is it deeper down on the angulation, or is it somewhere else? But all of those are fixable.
Great, thank you. And my final question and kind of a wrap up is, Scott, Cindy, and Dr. Laviana, we're going to go in that order. What is your one tip for people that are considering getting an Indiana pouch, or what's the one thing you want people to know? Scott, do you want to start?
I think a positive outlook, a positive, outlook on the surgery, being positive well before your surgery and getting in physical shape, physically, nutritionally, and emotionally. People say there's support groups and things like that. It's not that much different than anything else that I've had to do. I'm voiding a little differently, but other than that, it hasn't affected my lifestyle that much. And in all, thank God I got it taken care of, and I wouldn't change anything. Or well, I would, I'm having had cancer, but other than that, it's all good for me. And I'm positive about my experience.
Great. Cindy, what would you tell? What's the one thing you would tell somebody?
I agree with that, but I would also say go into it with knowledge. Do your own little homework to figure out if this is for you, but don't be afraid of it, because it really changes your life for the better. I would say that it does not change your life for the worse. It changes it for the better. And you got to have a happy attitude. You got to keep a positive attitude and keep God on your side. You got it made. Good doctor, it's good.
Great. Dr. Laviana, what's the one thing you would say?
They go somewhere with experience where they do these cases, they understand the ins and outs. Don't expect just a 100% smooth ride that you're going to get this done and it's going to be gravy and there's going to be no complications or no issues. I mean, both our panelists here had to undergo some revisions and changes, and that's, I would almost say, is more normal than not. But just understanding that things will happen along the way, you can't predict them, but there's solutions to all of it to get a great outcome. And if you can roll with that, and then understanding you're going to have to catheterize the rest of your life, and having a great concept of what that actually entails. I do find sometimes that not everyone grasps that fully, and so I like to have patients basically even catheterize before, just so they understand what the actual motion is and what it is, even though it's different in your abdomen versus elsewhere, but just to kind of get a sense of, okay, is this something I can do?
Absolutely. I want to thank everybody so much for their